Exactly, sir. Exactly.
Jay, sorry.
It's okay, sir. It's okay.
Oh, all right. Okay. So, all right. So, okay. So I'll leave it on, and then I start at 4 o'clock. ठीक है?
Right. Right. Sir.
Okay. I don't leave. शुक्रिया जी बहुत बहुत.
Sir, welcome. Welcome, sir.
Okay जी.
Assalamualaikum Iqbal sahab, sir.
Dr. Vikas, can you hear us?
Ji, I can hear you.
Okay, sir. Your co-host now. You can check, sir.
Thank you so much. Ji, I can mute myself. Excellent. Dr. Iqbal, Assalamualaikum, sir. Can you hear me?
हाँ जी, I can hear you. And
sir, how are you?
So I'm अल्लाह का शुक्र है. आप सुनाइए. How are you?
बिल्कुल ठीक ठाक sir. बिल्कुल ठीक ठाक. Where are you right now, sir? आप इस वक्त यूरोप में हैं या US में?
Actually, I'm in Geneva, Switzerland. So,
all right.
Yeah, much better than in Boston. I will be in Boston on 11th of July in 10 days.
Excellent.
9 days. So, how are things?
The things are going very fine, sir. Thank you very much. How is your summer going?
Okay, Ji, just in between one and the other presentation. So, but hopefully it will be. I have another one on Tuesday on infertility, so which is totally different topic. And so the WHO की meeting at. So, so after this one, I have to start preparing for the next one. So,
the burden of knowledge, sir, we have to share.
Well, let's see. और वो जो है, so university is open now. Classes are.
Sir, we are closing out. This is the last day of classes, and then we have a week's preparation week, and after that we've got the finals week. So operationally speaking, university is closed from tomorrow.
Oh, I see. Okay. So yeah, most of the people would be interested in leaving rather than staying.
Yes, sir. Yes, sir. Especially the students, most of them come from, or at least many of them come from outer stations. So सारे इस वक्त जो है वो अपने, क्योंकि हमारे exams जो है वो इस दफा online ही होने हैं.
Oh, I see.
So a lot of people will be leaving campus.
Okay.
And you're teaching the summer semester in Boston?
Gee, so I will be, yeah. Actually, I don't teach. I do mostly research. So I will be doing. I have some projects that I will be working on, but I don't teach on the classes. I do seminars and other things, but not a course. So.
Okay, excellent.
Which is a good thing.
So yes, sir. The restful summary.
Yeah.
Just out of personal curiosity, sir, when you went back to the US, I think you flew directly from here to the US.
No, I flew back to Geneva, and now I'm flying to US on the 11th.
So when you reached Geneva, what was the protocol like?
Oh, yeah, nothing special. I already have a visa here, so no problem. You have to have the vaccination. Pakistan, koi quarantine nahi tha, there was none, so that was good. USA maybe koi quarantine nahi hai, so I think that's a good thing.
Excellent. Welcome, Sabahat Saab from Population Council. Long time, sir. Welcome.
Okay. Assalamu alaikum, sir.
Yeah, hi there. Thank you for welcome. Hello, sir.
आप इस्लामाबाद में होते हैं, इस्लामाबाद से कर रहे हैं join?
Yes, sir. Population Council बिल्कुल इस्लामाबाद में based है, sir.
Right.
Yeah, I'm based here in Pakistan office, so I work with Dr. Zebus.
Oh, I see. Yeah, yes, I know her for a long time. Yeah, I read your paper with Batul on Decence 4. So that was very well. A very
Yeah,
good
thank you
review.
so much.
Yeah.
Great. Thank you, sir. And nice to, to be here, to listening to your lecture today.
Yeah, I'm using all the information that you have put together and others, Zeba and so forth.
Yeah. Yeah. So I'm glad. Great, sir.
Good.
Assalamu alaikum, Dr. Bhatti Saab, sir. Welcome.
Ji, walaikum assalam. Thank you very much.
Welcome, Madam Zalla. Assalamu alaikum, sir. Dr. Sikandar, sir. Assalamu alaikum.
अस्सलाम वालेकुम जी, क्या हाल है?
Sir, बिल्कुल ठीक ठाक. Sir, may I introduce Iqbal Shah Saab, sir? He's the keynote speaker today from he's in
जी,
Geneva,
sure,
right?
sure. जी, please.
Assalamu alaikum, sir.
जी, अस्सलाम वालेकुम, Dr. Sir. Good to see you, जी, and most welcome.
Thank you, Shakir.
Sir, I would also like to introduce you to Madam Zalla Khatak and Sir Sabahat. They're both from the Population Council.
Assalamu alaikum.
Welcome, Dr. Edith. Sir, it's 4 o'clock. With the permission of Dr. Sikandar and Dr. Addleton, should we commence?
With Dr. Addleton's permission, please.
Sure, that's okay. I was going to say I think Dr. Iqbal is the most important one to concur here. If he's ready to go, are you connecting from Boston?
And actually, I'm in Geneva. I'm in
Geneva.
Geneva.
Okay.
Yes, I'm going to Boston on the 11th of July. So
Okay.
yeah, it's one of the few things for me to do before I leave.
Okay. No, we appreciate it very much. I guess the time difference is a bit better for you than if you were in the States.
Yes, exactly. That's why I wanted to do it before I go to Boston. So, so I'm happy.
Well, I know I'm going to give some open remarks, but I don't know if Dr. Vikas is the one that starts it off or if I should just launch into an introduction.
Yes, sir. I'm just going to invite Ms. Nida and Hafiz Sujasa for recitation of from the Holy Bible and the Holy Quran, and after that, sir, we'll just commence.
That sounds good. Thank you very much. Much appreciated.
Good morning, good afternoon, and welcome all of you on this webinar that was arranged by PRC. I know this is the last day of classes, so this requires an extra effort on the part of everybody from FC to join in, and it is much appreciated. Before we begin, I would like first, with my thanks, to invite Hafiz Shujawakar Saab to recite some verses from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الناس اتقوا ربكم الذي خلقكم من نفس واحدة وخلق منها زوجها وبث منهما رجالا كثيرا ونساء واتقوا الله الذي تساءلون به والأرحام إن الله كان عليكم رقيبا وآتوا اليتامى أموالهم ولا تتبدلوا الخبيث بالطيب ولا تأكلوا أموالهم إلى أموالكم إنه كان حوبا كثيرا. Translation. O men, fear your Lord who created you from a single soul, and from it created its match and spread many men and women from the two. Fear Allah, in whose name you ask each other for your rights, and fear the violation of the rights of the womb relations. Surely Allah is watchful over you. Give the orphans their property, and do not substitute what is bad for what is good, and do not eat up their property along with your own. It is surely a great sin. Sadaqallahu Azim.
Thank you very much, Hafiz Sahab. I would like to now invite, with my thanks, Ms. Nida Mumtaz to recite some verses from the Bible.
Good evening, everyone. I'm here for the recitation of Holy Bible. Proverbs chapter 1, verse 22 to 25. How long, O simple ones, will you love being simple? How long will scoffers delight in their scoffing, and fools hate knowledge? If you turn at my reproof, behold, I will pour out my spirit to you. I will make my words known to you. Because I have called and you refused to listen. I have stretched out my hand and no one has heeded. Because you have ignored all my counsel and would have none of my reproof. Amen. Thank you.
Thanks a lot, Ms. Nida. I think it is time that we kick off our proceedings by inviting Dr. Jonathan Attleton to please deliver a welcome note to our guests and our worthy keynote speaker.
Yes, no, thank you. Thank you very much. I also appreciated both the recitation from both the Holy Quran and the Holy Bible. I think both very appropriate for the occasion. I do thank Dr. Vakar and Foreman's Population Center for organizing this event. Thank those who are connected by Zoom. I see it's already doubled in number since I first connected myself, so that's terrific. And of course, thank Dr. Iqbal Shah for providing what I'm certain is going to be an interesting, informative, and thought-provoking presentation. I'm hoping to stay to the whole presentation because I'm interested in the subject, interested in demographics generally, and maybe Dr. Iqbal can confirm if I'm right or not, but I think when I was born in Pakistan, in Murree, Pakistan in 1957, the population of then West Pakistan was at something like 40 million. And I think about my lifetime, I realize I'm an old guy, but that's a lot of increase in that period of time. And of course, a lot of demands on the society, on the economics of that society and the politics of that society as well. So I think that this really promises to be pretty interesting, especially if that fivefold plus increase that I'm thinking about in my lifetime, that's pretty remarkable when you think about it. And it's certainly hard to imagine anyone better suited and better prepared to address this topic of family planning in Pakistan than our speaker today. Currently at Harvard School of Public Health, T.H. Chan School of Public Health, and principal researcher for some global health and population projects, two large multi-country projects over several years. And has also, of course, undertaken other kinds of research and work in the US, in the UK, in Switzerland, where he is right now in Geneva, and in China. Senior positions at the World Health Organization, obviously that's especially appropriate. Given the hat I wore earlier in my career, and for much of my career at the USAID, I was happy to see also that he's the recipient of a USAID award, the Marjorie C. Horn Operations Research Award. And I think it's not just because of that aid award, but also I think about the connection, if you will, between research, maybe call it applied research, and operations is one thing that I think is recurring in actually many of Dr. Iqbal's articles. These are all peer-reviewed articles, but again, this sort of connection, if you will, between research and the practical policy-oriented perspective, I think is something that's very important that be part of the discussion too. So without any further comment, let me pass on the microphone to Dr. Iqbal Shah with a lot of thanks and appreciation on behalf of Foreman for participating in this event today.
Thank you very much. Thank you so very much, Dr. Edelton, for the most kind and generous introduction. It's truly a pleasure to be here with all of you to share some of the work that I have done. I should acknowledge right at the outset that most of my work until recently has been in other countries, and I have benefited a lot from the seminal work, especially by the Population Council and other colleagues in Pakistan. And I will like to present some of a kind of an overview. And indeed, it will refer to the growth of population and other things. Before I burden you with lots of figures and graphs, and I would like to share with you an interesting exchange I had with a Chinese official in one of my visits to China. He had just come back from Pakistan after a visit and had been to Lahore. And I was excited, and I asked, expecting that he would mention about, Badshahi Masjid or Lahore Fort or Shalimar Garden. I asked him what was the most memorable sight that he saw in Lahore. And he mentioned, well, actually, the thing he actually remembered most about Lahore was how many children were riding on a bicycle or a motorbike with their parents. So being disappointed with his reply, I said, well, actually, our public transport system is not as good as yours. So he responded immediately. He said, no, the Pakistani couples have too many children. It's not the issue of transport. So that made me totally speechless. So this is just as I was preparing, I recall that conversation, and I also found this cartoon that reflected what he was trying to tell me about. So I think as Dr. Edelton, you referred to about the population growth, I'm sure you all know Pakistan is growing much rapidly than most of the countries in the region. So the latest, these are the figures from 1951 to 2017 census. And the population has grown, as Dr. Edelton mentioned, more than close to 6 times since 1951. And it has, it will continue to grow in 2025 and 2030 with a rapid pace. Actually, from 1951 to 1981, the population increased by 2.5 times in 30 years, whereas from 1981 to 2017, it increased also by 2.5 times, 2.5 times in 36 years. So from 1951 to 2017, population has increased by 5 times. However, it will double in 29 years with the current growth rate that of 2.4%. There is no country, actually, India has a less than 1% growth rate. So all this high growth rate is mainly because of a slow decline in fertility. If you look at the 1970, 75, the total fertility rate, before I go on, by the way, please do raise your hand or say if something you like me to stop or explain. I'm going to, I will be happy to answer any question that come or anything to clarify. So total fertility rate is, as you know, is the number of children a woman is expected to have by the end of their reproductive life if they continue to reproduce at the current prevailing rate of age-specific fertility rates by age. So you see there is a very narrow range of total fertility rate in 1970-75, but as you come to 2015-2020, Pakistan has deviated and has a very high total fertility rate compared to other countries. In Pakistan, the total fertility rate in 2020 is 3.6 children per woman, whereas in all other countries, in India, Iran, Nepal, Bangladesh, it is less, 2 or less. What is interesting is that Pakistan is richer than Bangladesh and Nepal, yet it has a higher fertility than in those two countries, which kind of defy the convention wisdom that as you are more developed, you are likely to have less fertility. Now, the fertility rates are closely related with contraceptive use, and a slow increase in contraceptive prevalence in Pakistan is the main reason why fertility is higher and has remained higher in Pakistan. Comparing to other countries, if you see on the earlier period, like 1980 in Bangladesh or 81, and compare it with the latest year, you will find that in all countries, the contraceptive prevalence rate, which is number of women currently using a method among all women in reproductive age, all women meaning married women in reproductive age. What is interesting is to compare that in Nepal in 1981, the contraceptive prevalence rate was 6.8%, and it grew to 52.6% in 2017. Whereas in Pakistan, it was higher than in Nepal, 9.1% in 1985, but it only went up to 34.2%. So, comparing with all countries, Pakistan's increase in contraceptive prevalence rate has been extremely slow in Pakistan. Now, just going a bit into history, because political leadership is very closely associated with how countries, not only in economic, but other social and other spheres develop. So I just to briefly go over, actually, Pakistan was one of the pioneer countries in family planning, and family planning activities started in Pakistan even before the government took it over in 1953, when the Population Association started family planning in some cities. General and later President Ayub Khan was very committed to family planning program, and he initiated with strong emphasis on family planning. However, there was some design effect. It was mainly focused on IUD, intrauterine contraceptive device, and it was all based on incentives and targets. People were forced to meet certain targets, and there were incentives both for the clients and also for the providers to have IUD. The achievement was rather dismal, and as soon as Ayub Khan resigned, the whole program got discredited and totally stopped. When in between there was Zahia Khan, who didn't do anything about the family planning, but then when Zulfikar Ali Bhutto took power, during his time, actually, the family planning was given very low priority, perhaps because family planning was associated much more with Ayub Khan, and saying something about family planning could almost mean endorsing Ayub Khan or Ayub Khan's policies. So Zulfikar Ali Bhutto, very enlightened leader, yet he did not give family planning its due recognition or any urgency. However, they did, during his time, a couple of approaches were used, like continuation motivation system. And also contraceptive supplies were inundated with the assumption that if there are supplies, it would generate demand. However, that did not happen. Then, as you know, Zulfikar Bhutto was followed by Ziaul Haq. Ziaul Haq was very reluctant to promote family planning. He actually, during his time, TV advertising of family planning methods was banned. Family planning expenditures got reduced, and family planning was seen in a more multi-sectoral and broader context rather than just for contraceptive use. Benazir Bhutto, when came to power, she revived the family planning activities. She was a speaker at the International Conference on Population Development in 1994, and she spoke passionately about all pregnancies being wanted, all children born wanted and taken care of. During her time, a major initiative on lady health worker started, and health services were required to provide family planning. She was followed by Nawaz Sharif, and Nawaz Sharif did make public support to family planning, but the implementation was very poor. There was a low profile given to family planning as compared to other issues. However, there was a national conference during his time, which kind of brought attention to these issues. Then Pervez Musharraf, he also spoke about population policy, but more in terms of population stabilization and more on target on population growth and population than on family planning. During his time, a population policy was actually initiated and declared. From 2018, there has been a heightened attention to family planning and a much more recommendations on comprehensive way of dealing with it. The task force has been established. The recommendation of involving religious leaders and media. So it seems that there's a revitality given to the family planning issues under Imran Khan's government. So let me now just share with you some of the levels and patterns of contraceptive use. So the prevalence of modern contraceptives, it's which is essentially the percent of married women currently using a modern method by region, and the total fertility rate, which is the number of children ever born. They are inverse relationship where contraceptive use is high, such as in Islamabad, the total fertility rate is low. Where contraceptive prevalence is low, the fertility is high, such as in case of Gilgit. Well, actually, Gilgit-Baltistan is a kind of an exception. For some reason, there is a contraceptive prevalence which is quite high, but at the same time, the total fertility rate is high. But in other places where contraceptive prevalence is low, such as in Balochistan and in Azad Kashmir, the total fertility rate are higher. So it is quite well known that contraceptive prevalence, especially use of modern methods, is a primary way of reducing fertility. And in case of Pakistan, the contraceptive prevalence hasn't taken up and as a result, one would find that the fertility rates continue to be high. One very immediate, there are many consequences of low contraceptive use. One immediate and apparent issue is about the maternal deaths. And as Balochistan had the lowest contraceptive prevalence, can see that maternal mortality ratio is very high in case of Balochistan. So that's one consequence of having too many children, which lead to maternal deaths and morbidity. In Pakistan, what is quite interesting is that the fertility is happening mostly on earlier ages, younger ages, 15 to 19, 20, 25, the peak age being 25 to 20, 29, but contraceptive prevalence starts to take up much later at 30, age 30 and plus. So the, there are 13% of women who give birth before age 18, and and there is a high unmet need in this younger age group. You can see that the age 15 to 19, the unmet need for family planning, that is unmet need is women who say they don't want to have another child or want to have a child after 2 years, and but not using any contraceptive method. So in case of 15 to 19, there are twice as many women who don't want to have a child and not using a method compared to those who are using a method, which is 7.4%. In case of 20 to 24, it's about the same. Those users are just as many as those who have an unmet need for family planning. That is that they want to space or limit the childbearing, but they're not using any method. However, as it goes in the opposite direction as it grows older. So I think these are the younger age groups which really are contributing much more to fertility and not using contraceptive methods and have a unmet need. So
चुताल कभी भी इधर उधर नहीं हो सकता, चुताल आसमान पे चमकता है और वो चमकता है.
Okay, I think there's someone else presenting also, as it seems. I think we saw that in the federal administered tribal areas, under half of first births are among teenagers, and contraceptive starts mainly after age 30, while peak fertility in age 25 to 29. So another very unique feature of contraceptive use in Pakistan is the high use of traditional methods, mainly withdrawal. So since 1991 to the latest survey 2017-18, there has not been a shift in terms of people switching from modern methods switching from traditional methods to modern methods. They both have increased, but in parallel, there has, in other countries, what has happened as contraceptive use picks up, most of those who are using traditional methods actually drops down and start to use modern methods. But that trend has not been found in Pakistan. What is also interesting, again, contrary to what is expected and found in other countries, is that there is a high use of traditional methods in urban areas and also among more educated and more wealthy women than those in rural areas, no education or poor. Now, this is contrary to what is normally expected, because it is expected that women in urban areas or more educated or wealthy in quintile can afford modern contraceptives, have access because they are closer to the service. Yet in Pakistan, it seems just the other way around. So obviously, either there is some fear of modern methods that is causing, or there are issues that makes it modern methods not attractive to those who are better educated. Another issue in case of Pakistan is a very narrow or very skewed method choice. 80% of all use is accounted for either by traditional methods, which is withdrawal, or by male condom, or by female sterilization. So pill, IUD, injectables are not used very often. It is only three methods: withdrawal, male condom, or female sterilization that actually are accounting for most of the use. Now, because of this limited choice and limited use, it is also leading to high discontinuation of contraceptive use within 12 months. In fact, almost one in three stop using a method within a year. Much more so in case of injectables and pill, which is almost about 1 in 2, as compared to male condom and withdrawal. Again, this probably reflects the lack of counseling, proper counseling about the choice of the method and other methods that they can switch to, as well as some of the quality of care that may also affect a higher discontinuation. Here in this figure, I have drawn discontinuation either because of the side effects or because of the method failure. Obviously, the methods which are good in terms of very little side effects, they are at the bottom in terms of the side effects or health concerns, such as withdrawal and condom, with very few side effects reported by women. Are discontinued because of method failure. They have a higher method failure, and that is the reason for their discontinuation. Methods which are more effective, such as injectable, are actually discontinued because of the side effects, very high on side effects, but much less due to method failure. The method that seems to be optimal in this condition is IUD, which has, compared to other methods, less discontinuation because of the side effects and less discontinuation because of method failure. However, IUD is not that commonly used in Pakistan. So the method that would provide optimal protection is actually among the least being used in case of Pakistan. Now, I should say that discontinuation by itself is not an issue if there is a prompt switching to another method instead of abandoning. However, most of the users in Pakistan, once they discontinue, they actually stop using any method and experience a pregnancy. So there have been a question with this history of high fertility and other low progress in contraceptive uptake. People have been asking questions about, is there really a demand for fertility regulation in Pakistan? There have been numerous papers, and in fact, one of the very good report is by Sabahat, who I'm very pleased to note that it's here, together with Batul Zaidi. In addition, there were papers by late Abdul Razak Ruknuddin and Karan Hardy on Can Family Planning Succeed in Pakistan? There was an older paper by Warren Robinson, What Went Wrong with the Family Planning Program in Pakistan. So there have been a number of studies that actually discuss this issue and question whether it is really family planning is really something that is needed or there is a demand for it. I should like to say that yes, there is indeed a demand for family planning, and the evidence for that comes from the very high level of unmet need that one can find in all countries, in all provinces, and especially in Balochistan and in Gilgit-Baltistan as well as in Azad Jammu Kashmir. Again, this reflects where contraceptive prevalence is low, the unmet need for family planning is generally higher. Some of the work that Population Council has done also show that unintended pregnancy rates have risen from 71 per thousand in 2002 to 93 in 2012. In 2012, there were 4.2 million unintended pregnancies that occurred. Half of these ended in induced abortion, and 34% were led into unplanned births. So estimated incidence of induced abortion is 2.3 million, which lead to a national abortion rate of 50 per thousand women aged 15 to 49. We can also look at total wanted fertility, which is 2.9 children, that declined from 4.3 in 1990-91, whereas the current fertility rate is 3.6. So it also shows that the wanted fertility is much less than the actual fertility or estimated fertility that one could find. Another support comes from the question of asked to non-users whether they plan to use later or unsure. So there are almost 50% who either plan to use, 33% want to use later, and 21% were unsure. If those unsure become sure, you could have at least half of non-users using a contraceptive method later at some point. I think two things that Sabat and Batul address, among other arguments, is one is about the husband's opposition. It's generally thought that husbands are opposed to family planning. However, if they are using condoms or withdrawal, it means they are not as opposed as they are perceived to be. And actually, some of the studies show that in the new program of lady health workers and village family workers, many of the husbands take their wives who are working on motorbike to nearby villages. So, and by that, they are endorsing family planning as such that they are not against it to stop their wife or sister from work in family planning. And also, the other issue about religiosity, I think one could say with the high rate of abortion that obviously religiosity or religion is not a deterrent to regulating fertility. No woman wants to become pregnant in order to have an abortion. Obviously, these high rates of abortion shows a failure of services in terms of meeting the demand for family planning. So overall, I think one can safely conclude that there is a big demand for family planning in Pakistan. Some of it is met, but others is not met. So what are the issues and challenges in terms of on the way of achieving high contraceptive use and reducing fertility? Well, one major issue is that the infant and under 5 mortality in Pakistan remains high. And again, if you look at it in the earlier time, 1970, 75, there has been a narrow range of under 5 mortality. And in fact, Bangladesh and Nepal had higher under 5 deaths of 251 per thousand and 250 for Nepal in 70, 75, but they all achieved a much greater decline in under 5 mortality than in Pakistan. Pakistan has twice as high under 5 mortality as compared to Bangladesh, which is 32, and Nepal, which is 34, and India, which is 39, but Pakistan has 75 per thousand, which is quite high. And in case of Iran, it's only 15. So Pakistan is doing poorly in terms of reducing under 5 mortality. And where this shows where under 5 mortality is high, the contraceptive, the the fertility is also high. So there is a positive relationship between under 5 mortality and fertility, both in order to replace a child death, it is compensated by almost 2 children to be born. So there is also very poor coverage and quality of information that is provided. There are large cohorts of young people who enter marriage with little or no information in Pakistan. DHS shows that only 15% of women knew of any contraceptive method before marriage. That is extremely low figure, especially for women who are entering marriage not to know of contraceptive methods. Few women in KPK, Balochistan, Gilgit and Baltistan, and federally administered tribal areas have seen or heard a family planning message in the past few months. And you can see that it's much better in Pakistan, in Punjab, than in other places. So again, providing information is the very simple first initial step, which is not even done very well in case of different provinces and regions in Pakistan. There's also a low level of information provided to women in terms of side effects and what to do if you're experiencing side effects, and about information about all methods. So you can see that only about 19% are told of all these essential elements for making informed decision about contraceptive methods. So that's a poor quality of information provided and counseling provided to clients who could potentially use methods for a longer duration. There are also major health system challenges. There's a lack of coordination and clarity of roles between the Department of Health and Department of Population Welfare. Department of Health facilities have a better coverage. They reach out to many more places. There are more facilities, but they do not accord high priority to family planning. In contrast, Population Welfare Department give high priority to family planning, but it has very limited coverage. Their facilities are much fewer than Department of Health facilities. There is a lack of standards of quality assurance in the private sector. There is no mechanism to provide quality assurance for the services provided by the private sector. Lady health workers, a very impressive program that was initiated in 1994, is part of Department of Health, but they are overburdened with tasks that take priority over family planning. And in fact, the last evaluation showed that on average, lady health workers spend 4 minutes to provide information on family planning as compared to all the other information with regard to maternal, child health, and so forth. So family planning is obviously receiving much less attention by the lady health workers, not because of lack of interest, but because they have so many other things to attend to, including immunization, child health, maternal health, nutrition, and so forth. So then the supply of contraceptives follow a predetermined procedures which are not related to demand, but they are sent. Sometimes it's overused and other places it's underused because of the demand and not properly in line with the demand and need. So overall, I think as I referred to earlier, there has been until rather recently a lack of strong political support to family planning. And in fact, whenever it is discussed, it is discussed more in terms of population growth than family planning, but population growth is closely related with fertility and family planning. But I think most people find it safer to talk about population rather than about family planning. They remain to be high family size desired, about 3.9. I think it would be interesting to see if COVID-19 has actually changed this desire. There's a young age at marriage, early onset of childbearing, 8% start in age 15 to 19, and it has reduced, but still it's quite high. There is a late uptake of contraception. So another issue that has come out to be quite conspicuous in case of Pakistan is that there is much less interest in spacing childbearing as compared to limiting. Most of the use is of female sterilization after achieving or even surpassing their desired fertility size. And it is also other systemic issues are the low female literacy, which is quite prevalent, and also very low female labor force participation that interestingly has gone down in recent years. Also, the empowerment, it's very low compared to other countries. There's low female agency. Only 36% report having the final say in own health and other matters like making large purchases or visiting friends or relatives. Mobility is especially limited in rural areas. So now there are, of course, promising examples. So it is not all serious challenges. And what has been coming not only from Pakistan, but other places is an example of having mandatory premarital counseling and information on family planning and reproductive health as a part of health and family well-being. In Iran, anyone who wants to get married and has to undergo 6 hours of counseling on general marriage and family planning and other issues, which has very important impact on early contraceptive uptake after marriage and spacing the first child. In Malaysia, it is also required for Muslim couples planning to marry to undergo a counseling on family planning as well as on other matters. In China, it is also practiced and required. And I am hastened to note that this is being discussed currently. And in fact, SIND is making already progress in terms of making premarital counseling as a part of service provision. There's good evidence of already of creating demand of family planning through lady health workers. And it can be further strengthened by actually making them become pivotal in terms of generating and providing family planning. Contraceptive counseling during antenatal care, postnatal care, and immunization visits is a missed opportunity that can be availed. We know from the studies in Nepal, Sri Lanka, that antenatal counseling on family planning and especially postnatal counseling on family planning leads to high uptake of contraceptive use during the postpartum period. So it is something that has not been given attention, but I think it is a big potential in case of Pakistan. And strengthening public-private partnership in provision of family planning is an important avenue to pursue. Things have been already in progress, and it will actually be strengthened under the current emphasis on sustainable development and population growth. So the promising prospects which led one to be quite optimistic is the targets and recommendation of the Council of Common Interest, which has set the target of contraceptive prevalence of 50% by 2025. There have been also very promising results of demand generation intervention. For example, the FLA project that was undertaken by the Population Council, which showed that in 5 years, from 2007 to 2012, there was an increase of 7.4 percentage points in contraceptive use. There was increase in birth interval. There was an increase in uptake of spacing methods rather than just limiting on which has been the case. Another paper by Mahbub Sultan also shows that in rural areas, women who were visited by lady health workers and family planning workers had 1.74 odds of using a spacing method than women who were not visited. So obviously, community health workers, lady health workers, village-based family planning workers are important in terms of effectively raising the contraceptive prevalence and in voluntary family planning. Currently, the concerted efforts are underway to involve leaders, religious leaders, community leaders, and political leaders. And that is also a positive direction that lead one to be optimistic. Health benefits of birth spacing and prolonged breastfeeding are also now in center in terms of promotion of family planning, and that is culturally appropriate and a good entry for family planning. There is also a discussion of better use of mass media and social media, especially for young people who are much more inclined to use social media for information and other. So I think whereas there are longer term interventions that require, such as improving female literacy, labor force participation and empowerment, and reducing infant and child mortality. In the short term, addressing contraceptive needs of women who want to delay next pregnancy but not using a method is actually it's an important intervention that can immediately raise contraceptive prevalence over the target that was set. So if unmet need is met, the contraceptive prevalence would increase from 34% to 52%. So this is something that can be done and should be addressed in the short term. Actually, addressing unmet needs is a human rights imperative, and it is also with benefits for health and sustainable development. Primary education is another thing which is actually required that everyone goes through at least primary education. So if every woman has the chance to have a primary education, contraceptive prevalence would increase to 43%. And likewise, if it is secondary education, increase to 46%. So let me close by saying that meeting unmet need and demand for family planning is a human rights imperative, which is also central to saving and improving lives and also for sustainable development. I think what has been more in the discourse in Pakistan is the later part of sustainable development and population growth as a part of sustainable development. But I think we also need to address that it is a human right imperative, which has benefit for health, saving lives, and also contribute to sustainable development. So thank you so very much. I'm delighted to explain or respond to you, any questions you may have.
Thank you very much, Dr. Agarwal, for this wonderful and most informative presentation. We will now be taking questions. So please, if you have a question, go ahead and raise your hand and the administrator will unmute you. Thank you. Dr. Terence Hull posted a question. Can you comment on the sources of contraception public center or private providers? Also, are there no implant services in Pakistan?
Thank you. Yes. Sorry. Okay. Yeah. Actually, in the recently did a population situation report that include a lot of information. So the private sector role is increasing in terms of contraceptive supplies. Actually, it is all for most of these methods. Private sector is more critical than public sector. The exact figures I don't have it off right now, but private sector is increasingly becoming very important. Now, implants are not yet widely available and not widely used. Actually, DHS did not show significant number of users of implants, but that is definitely something that can be very useful together with IUD for long-acting reversible methods. Yes, I see some hand from Navid, please.
So, Mr. Naveed, I think you're unmuted. You can talk.
Tanveed, please unmute yourself. You can.
Hello, can you hear me?
Yes, but we can't hear you properly. Please, can you speak loudly?
Okay, my question is, sir, that is there any optimal level of population? Optimal level of population, because the population control policy now will have consequences after 20 or 25 years. When they join the labor force, there might be unintended, unintentional consequences. So how do we match the optimal level after 20 years that our policies don't have unintended consequences? Thank you very much.
Thank you. I'm sure there are others who can respond to this very important question. It is difficult to set an optimal level of population size in 20 years. I think what we have seen is that there is a replacement level of 2.1 for total fertility rate that is generally considered as a good yardstick for optimal population size eventually. But in terms of policies, I think it is important that we look at the demographic dividend issue and the age composition and pyramid. It is difficult to say what would be the optimal size. I think as long as the population is capable to grow in line with the growth of the resources and sustainable development, I think that would be the criteria, but not the absolute number. But I refer this to other participants who are very knowledgeable, more knowledgeable than I am, if they can also contribute to the discussion on this question.
Mr. Sabahat has something to contribute. Could you please?
Assalamu alaikum. Can I?
Please go ahead, sir. Thank you.
Assalamu alaikum ji. I'm Shahid Nusrat, Additional Secretary Population Welfare Department. Actually, I couldn't
Sorry for disturbing you. Dr. Swad, we can't hear you properly.
Internet connection, but I tried my best. Way forwarding presentation for humble question is regarding, as you said, and what policies to capture the to harness मेरी आवाज आ रही है? Can I ask a question now?
Yes, sir. Please go ahead.
I'm Shahid Nusrat, Additional Secretary Population Welfare Department, Punjab. Actually, as you rightly said, there is a future of youth, or we have to capture the demographic dividend, which we will be facing in near future. Sir, what policies or what projects should be taken on board to harness the demographic dividend, which will be available in future for Pakistan?
Yeah, thank you. This is a very important issue for Pakistan, and I think experience from other East Asian countries and Southeast Asian countries show that the most important steps to reap the demographic dividend with the growing cohort of young youth and young people are essentially education, labor force participation, two key, which is linked. And in fact, education of women and their work participation is very important to really ensure demographic dividend. And my colleague David Kenning, who has done work on it, and there's a chapter about it in Population Situation Analysis of Pakistan. Actually, he says that, demographic dividend is not a gift. You have to earn it. And in order to earn it, you have to have the right policies and right intervention, which essentially include skill and jobs for young people, which are kind of a bit longer term. But I think if one start investing, that would definitely ensure demographic dividend as it has in other countries. May I also refer to your point about the on the chat in terms of the commodities, then the registration of implants. Indeed, there has been a debate whether Pakistan should manufacture contraceptive commodities locally, and it has been said that it's probably not the effective use of resources. So, and IUD, there is no point about manufacturing IUD and perhaps also implants unless there's a big demand for it. So it's a question about demand and supply. So as long as it's being demand is met by international import, perhaps that's okay. But I think the big challenge is to promote number one, spacing methods, number two, long-acting reversible methods such as implants and IUD.
Thank you very much.
Sir, I have one question. What is the impact of having a large number of people who are living below poverty line and are unskilled laborers? So the cultural impact of living in an economic condition where large families are preferred because large families mean more income. What is the impact of that on the fertility rate?
Thank you. Yeah, this is a very intricate question about poverty and the family side. Now, intuitively, one would think that poverty should actually lead one to have fewer children because the cost of having children. But in Pakistan, it seems like that is not how it is shows. So poverty. Poor people seem to have more. And I think this is where the role of infant mortality and child mortality come in. So as long as mortality of young newborn is high, there is always a tendency to replace it by having more children. So in order to reduce fertility among the very poor, it is important to reduce infant and child mortality, which would then lead to lower fertility, lower desire for having children among the very poor.
Thank you, sir. Mr. Sawad, sir, please go ahead.
Yeah, thank you. Thank you, Dr. Shah. I mean, it was an excellent presentation, which covers the whole perspective of family planning in Pakistan, starting from the history and how program worked and how it got stagnated in the 80s and 90s. And then it worked very well in the 1990s of the LHW program. Well, again, I mean, when we look at the family planning situation in Pakistan, which is also covered in the population situation analysis recently being conducted. And right now we are also replicating the PSA for Sindh, I mean, the Population Council. So again, I mean, if you look at the history and the country examples, so I would say education is the best contraceptive. I mean, just repeating the slogan of the ICPD from 1994. Because just last week, I was just reviewing a literature on the, for example, the postponement of fertility in the West. So, I mean, I'm glad to see Dr. Gavin Jones. I mean, he's a great eminent scholar and a demographer. So in the West, when we look at the fertility postponement drivers, the only thing was the women employment. I mean, after their completion of the education, once you complete your education, almost more than 50% of the girls have completed their education in West. Once they complete their education, by the time they are about 20 to 25, and you were showing in the slides that in Pakistan, the age-specific contraceptive rate is very low for this age bracket, and the TFR is very high. So again, I mean, if our women will be educated, I mean, if they go for the university education, by that time their median age at marriage will increase, and it will definitely impact on the fertility. We really need to focus on these younger age bracket of 15 to 24 to 30, who are actually the cause of high fertility rates. And again, you're right, we have a high unmet need. I just want to add from our recent study, I mean, not recent, but from 2018, we were just working with the Guttmacher Institute. So where we have worked on the family planning and its outcomes. Annually, we have more than 10 million pregnancies in Pakistan, and just believe me, nearly 4 million are unintended pregnancies. The outcomes of these pregnancies, I mean, it's very strange. I mean, 60% of unintended pregnancies goes to the abortions. So as you were mentioning, referring to the Dr. Sattar's study on abortions, that we have 50% abortion rate in Pakistan. That is very high. So again, I would say without contraception, we cannot deal with all these, I mean, the severe health outcomes, I mean, unintended pregnancies or stillbirths, everything. So, I mean, it was a great presentation covering all the aspects of family planning in Pakistan. Again, this is the way how we can harness the demographic dividend. I mean, the Secretary Saab was asking. So you have to just focus on the education for girls, so that on their labor force, and once they are employed, I mean, they automatically we will be moving towards the replacement level fertility. And we have, I mean, just in Pakistan, our fertility is actually total marital fertility. All the births occur within the marriage, and we have more than 5% total marital fertility, which is 5.8 actually. So, I mean, it's very critical situation. So government of Pakistan will, I don't know, will really have to do something to uplift the contraceptive use in the country. The economists just argue that, I mean, we have to work on the economy and development, but actually it's a very long way. The shortest way is just meet the unmet need for family planning, focus on the things which are very easily and short term. Just focusing on the contraception, we can get a good outputs, I think. So thank you for listening. Thank you.
Thank you.
Thank you so much, sir.
So I would appreciate Dr. Shah's comments if you want to say something.
Thank you. I totally agree with you. Actually, that's very helpful, very good insights. I just noticed that Professor Gavin Jones is also, if there, he can add, he has done some work, extensive work on Pakistan, also as part of PSA, population situation analysis. So I'm pleased that people who are most knowledgeable are there to contribute.
Is this a good moment for me to make a comment?
Please.
Okay. I just want to say to everybody that, first of all, that Dr. Iqbal Shah was such a important member of the team that worked on the population situation analysis for Pakistan. And I think the presentation today just illustrates his tremendous knowledge of the family planning and reproductive health situation in Pakistan. And I just want to say that Iqbal, you made a tremendous contribution to the PSA analysis. And you know, the presentation today, I think everybody has gained an enormous amount from it. But if I can just make one comment on the there are so many issues that have come up today, and sometimes it's interesting to make a comparison from another country. Over the last few months, I've been doing a lot of work again for the UNFPA in Cambodia. And, you know, something like a population situation analysis, not quite the same, but almost the same for Cambodia. And when you look at some of the comparisons between, maybe you'd think it's a bit funny comparing Cambodia to Pakistan, but a couple of very interesting things. Cambodia over the last 2 decades has had an economic growth rate of 7% per annum, one of the fastest in the world. And this means that when we talk about the demographic dividend and absorbing, you know, young people into the labor force, it's much easier in Cambodia to do that than it is in Pakistan, because first of all, the growth of young people is particularly rapid in Pakistan, and also the economic growth rate in Pakistan has not been as fast as Cambodia. But one other thing also that is very striking in Cambodia is that education has advanced very rapidly as well, and pardon me, that includes gender equality. The proportion of girls and boys in secondary schools more or less the same in Cambodia. Now, you know, as everybody knows, that's a very different situation from Pakistan. And, you know, again, my argument for Pakistan, again, there are so many things that Dr. Iqbal Shah has mentioned, which are very important, like reducing infant mortality, and then all of the aspects of running a more effective family planning program. But one very important thing is the need to have a strong drive for educational development. raise the educational participation rates in secondary education and so on. And, it's been mentioned that the fertility rate in Pakistan, even among the better educated, is still above replacement level. But there is a strong differential, as Dr. Iqbal Shah mentioned. It's much lower for the better educated. And my hunch would be in Pakistan, if education really is pushed hard at the secondary level, things will change. I mean, education changes the whole of society. So it doesn't just change the attitudes of particular groups, but it changes the attitudes of the whole society. And also, once you have educated women who have the chance to be in the labor force, the opportunity costs of having children rise, and that affects their desire to have children. And in most countries, what happens is you desire fewer children, but to be able to raise them well. Sometimes economists refer to it as high quality children, fewer but high quality children, and that motivation will certainly come. So sorry, I've talked for too long, but I think those are a couple of interesting points to make about the issues for fertility trends in Pakistan. So how family planning is done is extremely important, and that's what's been discussed today. But these broader aspects of how the society and the economy are developing are also extremely important, and will have their spin-offs for fertility in Pakistan. Thank you.
Thank you very much, Dr. Gavin. Dr. Iqbal, would you like to comment?
Oh, I just want to thank Gavin for the very kind remarks and the insights. Professor Gavin has a wealth of experience, and I can't think of a better person to address this. And thank you for sharing these insights. Indeed, education is key, and that leads to labor force participation. And yeah, as Professor Gavin has said, the benefits go beyond not only for the person who is educated, but for the next generation and the next generation. So indeed, that is the way forward. But that is a longer term effort. So I think addressing both the short-term issues as well as the long-term structural issues are important. So it's not one or the other, but both, which is what the way forward should be. And I'm pleased to see that attention is being given to both the shorter-term needs and the longer-term needs. So I like to thank Professor Gavin.
Thank you very much, Dr. Iqbal, for a wonderful presentation. We were hoping for a wonderful presentation, but we got not only a great presentation, but an excellent discourse in the Q&A session. And I thank Dr. Gavin and Sabatsa for that. We're already 15 minutes over time, so I am going to request Dr. Sikandar Ayat, who is the head of PRC, to please deliver a note of thanks to all our guests. Over to you, sir.
Thank you, Dr. Bakas. It's my privilege to propose a vote of thanks to Dr. Iqbal Shah for a very informative and illuminating discourse and discussion on family planning in Pakistan, challenges and opportunities. A timely, indeed urgent concern for all of us here at the Population Research Center. Dr. Iqbal covered a number of trends in family planning, and indeed the government responses from time to time by the political leaders and their policies, especially with regard to fertility regulating practices and how to harness it. We are very thankful for that. His main emphasis, of course, was, or concentration was, on contraceptive prevalence in the country. Which obviously, as he pointed out, the rate being very low, extremely low. Population in Pakistan, as I see it as a layman, is a double-edged sword. it can have both favorable and unfavorable consequences. With more than 25 million people now, fifth largest populated country in the world, some calling it sixth, but generally I found it was fifth. And with the third highest growth rate of 2%, 2.6%, followed, only followed by Nigeria and Ethiopia with 2.6%. Of course, Dr. Iqbal mentioned 2.4% rather than 2%, which I'm quoting from some source. And with about 60% of the population under 30, the so-called demographic dividend we all talked about right now. We in Pakistan, therefore, need to figure out how to make the population an asset and not burden on the economy, state, and the society of Pakistan. We need to formulate and implement our public policy in a way that in the end, our population and particularly the youth would be an asset for the country. Perhaps as Dr. Devon suggested, through education and labor force participation, and the point was also well taken by Dr. Iqbal Shah. In his thoughtful, realistic discourse, Dr. Iqbal has identified and articulated a number of ways this could be done, and I need not recount them. I'm sure they are well received over here. I also wish to thank our participants for their very important, insightful discussion, exchange, questions and answers, though at times not quite audible, unfortunately, but thank you so much. I'm truly grateful to our rector, Dr. Jonathan Edelton, who has not only always participated in our webinars, but has been a steadfast and strong support to the Population Research Center, its aims, objectives, and goals. Indeed, population and demography has been his passion for long. As far as I know, having written a book way back in 1992 on the Gulf migration and Pakistan, a book I hope I can get from him one of these days. He had promised me earlier. It was published by the Oxford University Press. And if I'm not wrong, Dr. Edelton is here, maybe this was the first book that he got published. So it was on demography and population. This wonderful event, of course, did not happen on its own. Dr. Iqbal did not happen to pass by and we got hold of him. As he told us a little while ago, in fact, he's in Geneva right now. Dr. Waqas, Director of the Population Research Center, Mr. Jawad Tariq, Coordinator, and Ms. Zain Fatima, a staff member, made it happen. And I'm extremely grateful to them. This webinar, in fact, is a part of continuing monthly webinar series of the center. Finally, once again, I want to thank Dr. Iqbal Shah for his great presentation. I really enjoyed it and learned so much in the process, and his perspectives on family planning in Pakistan and the way forward. Thank you so much, Dr. Iqbal Shah, and thank you, everybody. Thank you so much for joining us this afternoon. Thank you. God bless.
Thank you.
Thank you, everyone.
Thank you, everyone. Thank you, Dr. Iqbal. I just wanted to add that the recording of this session will be made available on YouTube, I think. And if anybody wants a copy of the presentation, just send an email to PRC or Dr. Iqbal directly for a copy. Thank you very much for joining and have a great weekend.
Thank you very much.
Thank you so much.
Thank you, everyone.
Thank you, everyone.
Thank
Bye.
you, Shah.
Thank you.